Okay, so when I was asked to talk about pressure injury, I actually mentioned earlier that it was almost the same week where I was asked to look at a case for a very large health system in the Chicago metropolitan area where they were being sued, and I alluded to it before. And I was looking at, they already had a identified expert on the plaintiff's side who pontificated that hospital-acquired pressure injury should absolutely never happen. And when the lawyer called me, I said, well, I got it's a her. I said, I got her. He said, why? I said, because the National Pressure Ulcer Advisory Panel doesn't agree with that. I said, 10 years ago they did, but now they don't. So, and that was actually within 2 days of this, the email which you talked about this. And it made me kind of mused about what I know about them, and actually did some further reading to get me up to snuff, so to speak. So, pressure injury is, as we all know, the bane of our existence. The main reason we're all in the room. It's the main reason for, one of the main reasons for hospital readmissions in the United States, and it's going up, and we know that. And it's extremely costly both on the front side and the back side, meaning it's costly in terms of the healthcare system, in quotes, the United States, in terms of its impact on the transmission of cash. Its impacts in a negative way on hospitals themselves, both at the regulatory environment as well as in the payment environment. And obviously, it's something that we need to be very, very attuned to. So let's, and you know most of these things, but it allows us to sort of wet our whistle and get into a discussion. Tongue in cheek, so to speak, there are risk factors for pressure ulcer development. We all know them. These are not the only ones. But number one is the patient has the inability to either know they're getting a wound or vocalize that a wound is occurring. They may know it, but they can't vocalize it for a whole bunch of reasons. Number two, and maybe part of number one, is the issue with regard to moisture and moisture on the skin and what that does in terms of maceration, etc., creating an environment that's rife to begin to break down. Obviously, immobility is another one, and that immobility could include the level of just being sedentary, but also spinal cord injury, obviously, which is one of course, the major, I mean, I forget I was talking to about it during the break, but right now I can think of 6 or 7 patients in the outpatient setting that we're dealing with, all of whom have fairly significant pressure injury in various stages of healing, and they're all spinal cord injury patients. And then we have other patients that have significant immobility, some of which is self-created, and much of which is not. But this is a huge area, certainly in the outpatient environment, and obviously in the ICU. Nutrition intervention or nutrition intake is often talked about as one of the number 5 or 6. I'm not so sure about that. I think we do it statistically, but it's not that they're malnourished. Poor nutrition intake doesn't mean you're malnourished. Ask the patient that's got a BMI of 60. I mean, that's malnutrition, but from a different perspective. So if we include that, and we say poor nutrition intake, which includes massive obesity, et cetera, et cetera, et cetera, absolutely. It's a risk factor. And obviously friction and shear. And then I'm not sure these are ordered in the correct fashion, but certainly these are the top 6 that create a creative environment. If we define it, we all know what the definition is. It's a localized injury to the skin and or the underlying tissue below it. So it is an injury that starts at the dermis, but the reality is the dermis is what's affected, the epidermis is what's affected, but the injury itself typically is from what's something either outside in or inside out, but the dermis winds up becoming the affected organ. It can start as intact skin or an open ulcer. We know that. Intact skin being an area that is inflamed, red, etc., macerated. We often talk about stage 1 as a reddened area, but quite frankly, a macerated area can't get inflamed, can be a stage 1 as well. They're not always painful, but they can be. And then it occurs as a result of intense, and I don't, this is right out of a paper, but I'm not so sure it's intense because I think I have a slide coming up which actually brings the physical cause of pressure injury to focus. It's going to come up. And I'm going to stay away from that statement because the actual atmospheric pressure or the actual measured pressure surprises most people. There are extrinsic factors. They're all listed on the left. The intrinsic factors are on the right. And they intersect. All, some, one, two. And this problem in the middle becomes the perfect storm that sets the patient up for developing some type of a pressure-related danger zone, so to speak. I thought about putting Tom Cruise up there for the danger zone. This slide's out of order, so we're going to move on. The incidence of pressure injury, again, I did it on an airplane, sorry. Pressure injury affects about 2.5 million people as of 2016. Excuse me, it's probably higher now. The estimate is 60,000 deaths per year. I think it's probably higher. These are captured numbers. I suspect the numbers are closer to 80 or 90,000 in the uncaptured group that has related pressure injury problems that just doesn't get captured on various databases. That's almost, well, actually it's more than twice the number of patients that are killed by motor vehicle accidents in the United States. And age is a big factor. 72+% of the patients are over 65. And again, I'm not sure what to do with that data point because I'm not sure what that means. In 2021, the population's getting older, and I don't know what 65 means. I certainly don't know what 65 means. I think 65 is the new 45 myself. But again, it's a data, it's collected, it's okay, yeah, older people get pressure injuries. Now, here's one of my fun facts. If we take a piece of skin and apply 33 milligrams of mercury pressure, which, by the way, is not much of a handshake. Think about the blood pressure cuff. You pump it up on your arm, and when it gets down to 80, 60, yeah, maybe you can feel it. This is half that. That is the pressure within the capillary system. And anything over 33 millimeters that's put on a capillary bed will reduce blood flow. Now, sure, it's time sensitive, and that's why all of us sitting in this room for the day are not going to get pressure injuries. We're sitting on our butts, and it's certainly more than 33 milligrams of mercury pressure. And as I always tell patients, well, the good news is our autonomic nervous system is working, sometimes in overdrive, and we're moving. And if we put a camera up here and we put it on everybody in the room and we did a time sequence photograph, we'd find out that we're all dancing in the seats. That's an autonomic nervous system protective mechanism that we have physiologically. That's why we don't get pressure injuries, because we don't allow that to happen, because there's pressure sensors in appropriate areas of the integument that have feedback loops that move us. People with spinal cord injury don't do that, hence they're at very high risk factors. Other neurologic injuries, that's one of the reasons why diabetics are more prone. It's because of the neuropathies associated and so on and so on. But the point here is that at 33 millimeters of mercury, it occludes blood vessels. Intermittently when we're sitting in a chair, but if you have some type of an immobility, it occludes that blood vessel, which causes ischemia, which changes the metabolic process going on at the cellular level. And not to make everybody break out in a rash from biochemistry, but in fact that creates an anaerobic environment, and guess what happens? Cells die. And yeah, maybe a few die, and if only a few die, nothing happens and it's not observed. But if more than a few die and they keep dying, they become a toxic environment. underneath in the tissue, in that toxic environment now where there's cell death creates an inflammatory response, which goes back to the original set of slides, which creates the pressure injury. And that can eventually lead to soft tissue necrosis and eventually ulceration. This is cell death. That's apoptosis. That's a different thing. That's what happens in malnutrition or aging. The cells deregulate themselves, not because of pressure. And pressure ulcers can occur because of that as well. That's where the nutrition risk and disease manifestations, where it may not be necessarily specifically the amount of pressure on the area, but it's a small amount of pressure, but oh, by the way, the cells are dying because something else is wrong with the patient, or we're killing them with some drug or something. Over here we have tissue necrosis, and that's cell death because of something external. That would be the pressure itself with an otherwise healthy patient where they're immobile. But in either case, the result is still the same thing. It's cell death, and cell death occurs, and that creates a negative environment wherever that is, typically on the back. And we all know I don't have that picture, I decided to omit it, where there's all these pressure points on the back of the body, shoulders and buttocks over the coccyx and ischium, where ICD-10 allows us to code the pressure ulcers. Try coding one on the abdomen. There's no code for that. We found that out a couple of weeks ago. So we have to be creative when we're trying to report them. And they do occur on the abdomen, by the way, as we all know. Anyway, pathophysiology, again, just a quick review. Risk factors create an environment where the patient's at risk, typically over a bony prominence, but not always, because we have devices that can cause it, and we have patients with big, huge paniculi pushing on their own skin that can create. And by the way, you can't code that one either. I've got to come up with a code for that. We see that as well. It reduces perfusion, causes ischemic necrosis, and causes pressure injury. This isn't that old a slide, but it is already dated because it's pressure injury, not pressure sore. I talked about biofilms earlier. Biofilms become the bane of our existence once the injury occurs and the skin and integument is disrupted. Biofilms are the things that we try to attack both from outside and from inside. But remember that wound is isolated with regard to the body's physiology in terms of it's a space, and the inflammatory response creates sort of a wall between the open space and the integument next to it. And yeah, the skin that's often the misnomer, because we'll get a consult and the patient has the wound, and the first thing somebody did is put them on antibiotics because it's red. And then I'll go in and say, well, I'm not going to tell you not to use the antibiotic, but it isn't going to make it better, because that's not the reason it's red. It's red because the body's working. It caused it to be inflamed. And part of that is isolating the wound, because physiologically we do a really good job of isolating the wounds from the systemic circulation. But that creates a problem on the backside, because if we want to put some kind of medication in there, the delivery system in the vein isn't necessarily going to get it there, because it's an isolated environment, which is where the biofilm sits, and the warriors in the biofilm sit there and say, hey, try to get to me, you can't. Hence the reason for the need for debridement and dealing with these things and cleaning the surface. We have a lot of new agents that we can put on the wound that attack biofilms, and they're coming fast and furious. We historically had a bunch. They work really well, like peroxide. Peroxide works great, but it's cytotoxic. So if you keep putting it on the wound, yeah, you might break up the biofilm, but the wound's never going to heal because the cells are going to die. Non-cadexamer iodine, also betadine, works great, breaks up the biofilm, kills the bugs, kills the cells, kills the bugs. The wound's not going to heal. But we have newer products now that can help us break down the biofilm, and I'm not going to talk about the topics, the different ones. They're out there. Again, read this later. This explains how the biofilms, bacteria kind of exchanges the DNA and makes it, and I'm going to use the word superbug, but it's not the superbugs we're used to talking about, like super MRSA and those. These are not that, because they don't have labels, because they're specific to the patient.
They are sort of the walking dead of each patient because these biofilm actors are unique. Depends upon how the DNA sequencing was exchanged from one bacteria to the other. Obviously, therefore, a huge problem in trying to deal with them, and more often than not, the only way to deal with them is topically, not necessarily systemically. That doesn't mean you don't use antibiotics where they're appropriate, they do. But you can't just put the patient on antibiotic because the wound's green, so you think it's Pseudomonas. That's not going to kill it. It wouldn't kill Pseudomonas anyway if it's on the surface. So there's a whole world in dealing with that, which maybe we'll talk in Q&A. In the next generation, over the next 5 years, the data, actually I was just at the wound meeting a couple of months ago, or a couple of weeks ago actually in Vegas, the fall wound meeting, the spring one, there's going to be more of this out there. I'm actually working with a company on this. We're actually going to be understanding the DNA sequencing of the biofilm bacteria, and we'll be able to identify what they are and try to address it with various specific targeted materials. Obviously, all wound management requires these things. We all know them. In the wound care world, if you go to the wound care meetings or you go to the proprietary wound care centers, which are probably fast disappearing, we're not one, by the way. The word on the street is that we should achieve 95% healing, period. And that includes pressure ulcers. But remember, that doesn't say 100%. Now that's a problem because most institutions now are targeting zero pressure injuries. Now that's not zero pressure injuries in terms of the outside world, but that's no pressure injuries, no HAPIs, pressure injury, hospital-acquired pressure injury within the institution. And there are a number now that are reporting that. Now, I don't know how they're achieving totally zero, quite frankly. I think they're fudging their data a little bit. But there's a bunch of institutions out there, one of which is, I have a nephew who's at the Brigham. The Brigham is zero in their data. There's a hospital system in Tampa, Florida that's zero. I actually know the people at the Brigham, and I believe it. There probably are zero, but they have more money than God, and they
have FTEs.
Yeah, they have lots of bodies, lots of eyes, and somewhat of a captive medical staff. My nephew is a member of the Harvard faculty, and they are a captive medical staff, and they sort of march in lockstep, even though they're super brainy. But anyway, the goal is to achieve 95% healing rate. That's not incident rate. Zero incident rate is what we should see. But that also means that 5% of pressure injuries, 5% of all wounds are not going to heal. And we have to be aware and cognizant of that. And we have to know when that's going to occur, and we have to plan for that. And that's another whole talk about palliative wound care, which is a whole separate discussion and a whole separate workshop. But that exists, and it's real. And at least the National Pressure Ulcer Advisory Panel has actually, I think in the new standards, actually talks about that. And obviously, the last thing is the most important, is prevention, which is the bane of all of our existence. And we're not going to prevent all of them. We just aren't. And they're going to happen. The question is making sure that we understand when they're there, identify them quickly, and make strategies to try to reduce the effect and get them to a point where they do heal. So preventing them is easier said than done. No pressure, no ulcer. That's sort of the old mantra. That's really not true. Pressure ulcers can occur even when there's no pressure. That's another whole discussion, which has to do with pressure within tissue pressures and things within the integument. And yes, some, if not all, or most hospital-acquired ones are unavoidable. Most. Some. Not 100%. And if anybody is getting dinged because somebody says they're all unavoidable, please call me. Because I would love to go toe-to-toe with them. That doesn't give us an excuse. Well, they're not all unavoidable, so that just happened. But obviously, some are. We all know this, but just to sort of give a cross-sectional discussion, Stage 1, the skin's intact, but it's really not. I hate that word, because if it was intact, this wouldn't happen. So something's wrong with it. So there's a problem. It's usually non-blanchable erythema, means you press on it and it doesn't really get pale. It's still kind of red. Typically over a bony prominence, but doesn't have to be. Can be painful, but doesn't have to be painful. It does have a temperature variance from the surrounding tissue. And it can be difficult in populations with darker skin colors. And in fact, it's probably a big, not probably, it is a bigger problem in our patients that are not very pale. And that can be a problem. I don't know of anybody that's done a paper. It would be interesting for somebody to do a research on the when the incidences occurred in the darker skin races. I would proffer that stage 1 injuries are statistically identified at a lower percentage rate. Stage 2 is probably at a higher. There's a higher percentage of stage 2s, but that just is because the stage 1s don't get identified. And that's that's what a stage 1 kind of looks like. Blanchable, non-blanchable, very important. Although that's not, by the way, that's most of the time, but some of the time it doesn't hold true. Stage 2, partial thickness, thermal loss, some open shallow ulcer. These are the slides that all the providers should be seeing, by the way. I know you know that. Sometimes the skin may be intact, but there's a dermal destruction and it creates a blister, and it may be filled with serum. If the blister's still there, but the skin's intact, that's technically non-stageable. But I could argue that it's probably a stage 2 because it's a blister. Anyway, that's sort of getting into the weeds a little more. We shouldn't use it to do things like skin tears, tape burns, perineal dermatitis, maceration or excoriation, but a wound that's an area of skin that's macerated, it's kind of, and especially on a bony prominence, that's kind of at least a stage 1, and we don't identify it that way because we don't want to ding ourselves. And that's typical of what a stage 2 looks like, and that's often misdiagnosed, by the way, or misstaged. Obviously, for stage 3, full thickness goes through the layers of the skin to whatever's below. Whether or not slough is present is not necessarily a identifier mark, but sometimes the slough gets in the way, and which then we don't stage it correctly. Sometimes when we get these acutely, and we have a fair amount of necrosis, and we have slough, and it's been already staged as a stage 3, we will say unstageable because we don't know what's below it. And then we'll go and debride it, and then we'll stage it. Which is a problem for payment, by the way, because if it's unstageable, then Medicare and some of the payers don't want to pay you to debride a wound. So we get in that battle. But anyway, typically the stage 3 pressure injuries are pretty obvious, but as I said, sometimes there's some subtleties. Stage 3 also can change depending upon where it is, and it's problematic. We see a fair amount of in the center we see them. They're from all over the place. In the occiput, on the sides of the face, and so on. And they're usually understaged because there's no fat below them. So they're usually staged. Typically, we'll see them, and somebody says this is a stage 2. We say no, it's a stage 3 or 4 even sometimes because of what's not underneath it. These are actually stage 3s. The one on the left actually is granulating, so notice how clean they are. And obviously stage 4, and we all know about that. And that can include, if it's over a bony prominence, obviously you can get into the debate about osteomyelitis and exposed bone. Nobody's answered that yet. Some people argue that if the bone's exposed, then it's contaminated, therefore, by definition, and it's got bacteria and bioburden on it. Some people would argue, well, no, if it's not soft, it's the outside of the bone is dead and it's not living tissue, so you really can't call it an inflamed bone. I'm not sure I know whether I care about that or not. But obviously, the deeper the wound and the more tissue that's involved, the more difficult it is to manage moving forward. And these are stage 4. That's muscle fiber. Then we got deep tissue injury because we don't know what to call it. It's a bruise. And related to trauma of pressure. And that can be a wheelchair side. It doesn't have to be a bed. It can be the patient's leaning on the wheelchair, or they were bounced from the operating table to the gurney and somebody said, oh, they got a bruise on their butt. Well, yeah, that's a pressure injury. That's a deep tissue injury, and we have to wait and see what it's going to do and demarcate. Obviously, these are things we watch, we isolate, we don't debride it, because the goal is hopefully the integument doesn't break down, the body's pretty smart, and maybe it'll clean it up, and if it'll clean it up, we don't have to do much but just isolate it and protect it.
Can I ask a question?
Yes?
So our coders are trying to call our deep tissue injuries unstageable pressure ulcers.
That's not what they are.
Well, but there's no code.
I know, well, like I said, there's no code for one on the belly either.
Right.
I mean, you know, I think you have to be creative. That's a whole different world. The good news is we have great coders, and I'll get an email or I'll get a little post-it. This is going to be and I'll go, sure. I can tell you as a provider, whatever they tell me it is, because especially when we went to 10, I have no idea. I look for codes, and there are codes. I mean, we've got into the code mess. Venous ulcers, right? There's probably 80 codes for venous ulcers. They all say the same thing, but there's only a few that you'll get paid for debridement, and they end in 8. And the only reason I know that is our coders said, you got to use the one that ends in 8. Don't use the one that ends in 0. Don't use the one that ends in 9. It says the same thing. So how the heck am I supposed to know? And I understand your pain. I don't know what to tell you to do. They're really not, but if it means you're going to get paid, then call. But the problem is on the other side, now you're getting, oh, by the way, it's a hospital-acquired pressure injury, but it's not.
What are other hospitals doing? How are you addressing that situation from a coding perspective?
I don't think we have our coders diagnose them as a pressure.
Okay.
They might not code them at all. Again, we're running into the problem where our providers aren't even identifying them.
Sure.
So I don't even know if I very rarely see in a provider's note deep tissue injury.
Yeah, that's universal. It's a big issue at our 5 hospitals. And the nursing staff, it's literally, and our wound nurses are pulling their hair out because unless they're here's the shape, then they don't have their But that's a big frustration, and we're trying to work on how we're going to do this. Nurses can't diagnose, and that's one of the things. In fact, I just got while I was here, I just got the email from our pro forma because we're trying to address that, and that's where the wound team is going to come in, and it's going to be provider driven. Therefore, it can make a notation with a diagnosis because that's the only way it's going to work. God bless our nurse practitioners. We have a nurse practitioner.
Well, I was going to say, there is a code for deep tissue injury. I've used it in the outpatient clinic. There is a ICD-10 code. I was trying to look it up on our record site.
It's new this year, I believe.
Excuse me?
I think it's new this year.
Yeah, I've used it several times, so I know it's there.
I was just
I
gonna
have
say,
it as
why
a
don't we
takeaway.
offer, we'll take that as a
Yep.
task item and
Yep.
send that back out to the group.
Yep.
Yeah.
I couldn't get onto the website, so otherwise I could have had that specific number.
And
for
just as a disclaimer, I just put down what I think the diagnosis is, and quite frankly, if I'm wrong, the coders just tell me it's this and they do it, so I know some of it. I'm not the coding expert.
Well, and the other thing that's happening to us is, let's say the patient comes into the hospital with a stage 2, right, on their butt. But over the course of the hospitalization, maybe it goes to a stage 3. So it's present on admission. Now they're telling us the stage 3 is hospital acquired.
It is.
Yeah,
It is, 'cause it
that is
advanced.
correct.
And that
I
is
wanna
true.
make sure I'm like,
Yes, that's accurate.
Yeah.
Again, we all feel your pain,
Yeah.
but unfortunately, that is absolutely true.
I'm making sure everybody.
And I'm not saying you should upcode it when it comes in, but I didn't say that.
As a former
We get into avoidable and unavoidable. Nobody should ever lie on a record. Avoidable versus unavoidable. I alluded to that earlier. This is 2014 in the PAUP. Actually, as I said, there's a new one. I think it's the end of this month, and it may be already out. It's out?
Well, they have a public comment that came out with all of their pieces to
Yeah,
this, and so,
but it's gonna be reprinted, but they
Correct.
commented on what they're doing.
yes.
All right, most pressure injuries are avoidable, but not all, and that's very important. It's very important in the tort world, it's very important in the regulator world. It's huge to get them to do that. Huge, but it's reality, and it took a lot of arguments to say, come on, guys, you know that they're not all avoidable, even though we're holding the feet to the fire of institutions right now. The ones that are not all avoidable are patients with hemodynamic instability that worsens with movement so they don't move. Somebody on a balloon pump. Somebody is in the ICU that's on a balloon pump or an ECMO. I mean, again, smaller hospitals don't deal with that, but the bigger ones do. And you can't turn the patient. You can't move the patient. And okay, yeah, we have the $20,000 bed, but it's not 33 millimeters of pressure or less. There's no way. Space station. Somebody have the money, let's get Elon Musk and let's go build a hospital that orbits the Earth. Inability to maintain nutrition and hydration status, clearly that's another risk factor which is unavoidable. Tiger by the tail, unstable patient, and their risks are high. And I would say to the staff is document, and making sure that we document that that's what we're dealing with here. And, you know, the Braden scale takes some of that into account, but not all of it. Just make sure that all those T's are crossed and I's are dotted. At least now we have this backup says, well, they're not all avoidable. And then some other things help a little bit, the A&D, especially if the patient is not allowing artificial nutrition and hydration, although hydration is not an issue in Iowa, but that's part of where the patient's created an environment. Never blame the patient, but if the patient's created an environment where we can't attack or address the issue, then we just have to say, by the way, pressure injury is unavoidable. And this patient, here's the reasons, which is really the document. We can't replace or turn the patient. I alluded to that. And even if we remove the pressure, the skin doesn't always survive. There's lots of other reasons for that, especially patients that come in that have coded, that have had incredibly hemodynamically unstable. Those patients, again, 33 millimeters of mercury pressure, external, no blood flow, internal is worse. I'm not going to read these, but these are the position statements. These may be the ones you have there. I just got these are their position statements, and it's in my slides, and you can go look them up. Position statement 5 to the comment there about the patient that came in with the deep tissue injury. Pressure injury may be more extensive than initially apparent. So that's sort of a catch-all to, well, when they came in, it would look like a deep tissue injury, but in fact it was, sort of retrofitting the admission statement, because now there's a position statement that allows you to do that. So that might be a way to help deal with that. Pressure injury may evolve into a full thickness wound despite optimal care. That's another PA thank you from them to argue with third party, and I'm not sure about how we're going to deal with CMS on that, but certainly it's there. And it should be treated with the evidence-based practice that we have at the moment, which of course changes. Hippocrates wrote there, well, in the Greek, which I don't speak, there are in fact two things, science and opinion. The former begets knowledge, the latter ignorance, which is something I like to tell the residents all the time. Now, as far as how do we treat them, this is kind of a scattergram because I'm not sure we have a direct do this, if that, do that. So it's institutionally directed, except for no pressure, no injury. Get the pressure off. That's universal. And then we get, well, what happens when I can't get the pressure off? Revert back to get the pressure off. You just find a way. The problem is often if you get the pressure off the right ischium, we get a left ischial pressure ulcer because we turn the patient, or it's on their shoulder, et cetera, et cetera. But there are some strategies which are universal and we hold true. Cleanse the wound, obviously we all know that at every dressing change, but making sure we don't traumatize the wound when we're doing it, especially if we have a healing wound that's granulating and we have good granulation base, what we don't want to do is remove that. What we don't want to do is injure that, because it took a while to create that. As far as what we use to clean the wound, we have a lot better wound cleaning products available now. I can tell you an anecdotal story. We can't prove it because we didn't track it, and I wish we did. When we started using Vosh in our outpatient center, it's a little pricey to use an inpatient, unless somebody will make it in a, we have oxygen, water, and Vosh on the wall. But hypochlorous acid, when we started using it in the wound center, and on every wound, we have a policy, when we finish treating a wound in the wound center, they get 10 minutes of Vosh, period, unless they have an allergy, which we haven't found yet. And the reason for that is when we started using it, we absolutely do not see MRSA in our wound center, period. No, haven't seen it in 18 months. We didn't track it until we realized it, and we would love to report it. It's anecdotal, and certainly we have seen way less community-acquired transmission of bioburden within our center. And yes, we use gloves, we use masks, we use gowns, depending upon the wound, not all the time, always gloves. And we are very good at that. That the only thing that changes, we added Vosh, and I don't have money in the company, I wish I did. But we have seen a total decrease, I won't say zero, but pretty close to see zero contamination, cross-contamination in our center. And we're talking now with the hospital about how are we going to bring that to the acute care setting. Don't have an answer for that yet because it's not really expensive, but it's not cheap, and it would be overused. It's kind of like the Veriflow thing if you want to have another whole discussion about how we're going to use that. Obviously, managing wound infections, especially in pressure injury, is significant, but most of the problem is it's misdiagnosis and infection when it's not. It's often the biofilm. Sometimes the wound will have colonization. There's a big difference between colonization and infection. I will say, quote, it's always cellulitis, end quote, but that doesn't mean it's bacterial cellulitis. Once the wound gets inflamed, it's cellulitis. That's a definition. But it is not necessarily bacterial. It's inflamed. In order to, this is sort of it's a little more difficult to do in the inpatient setting. We do it, and that is, if you're concerned about the bioburden in the film, in the wound, then don't use a cotton swab and culture it, because all you're going to get from a swab culture is whatever on the patient's skin or the surface of the wound. That's not the actor. That's not what's causing the problem. Remember, biofilms are tenacious, and it's underneath. It's on the surface. So if you're going to do that, you got to debride the wound first, irrigate it out, using saline, irrigate, and then maybe do a swab culture, although we try not to do those. If we're concerned about the bioburden within the tissue surrounding the wound, we actually do a punch biopsy and we get a quantitative culture. Quantitative culture comes back like a urinalysis. It comes back and tells you not just what, but how much. And we treat that the same way. So if we don't see more than 50, well, I won't say, there's sort of some other strategies, but if we see 50 or 25,000 colonies of an organism, that's not an infected wound, that's colonized. And quite frankly, you're not going to get rid of that bug anyway, so don't worry about it. The other thing is when there's they do a gram stain on those quantitative cultures, look to see if there's PMNs in a patient that's not agranulocytic. If there are, then this doesn't work. But if the patient is otherwise immunologically intact, if there are no PMNs and no organisms seen on the gram stain, even on the swab culture, I'm pretty sure that's not an infected wound. There may be a bunch of stuff there, but it's not causing a increased problem in dealing with it. And these are sort of subtleties, and they're mostly provider specific, but they are things that are important to understand. That's one way we don't abuse or overuse antibiotics. However, attacking the biofilm is very important always. You can do it with cold steel, a curette, a mist irrigator, or you can actually do it and then use some type of a wound wash, and there's a bunch out there. They're all appropriate. By the way, caveat, acetic acid gets rid of hydrogen sulfide gas. It kills nothing. Dermatologists say it kills Pseudomonas. No, it doesn't. It kills the gas. Gets rid of the odor. There's some data that says maybe it ruptures the cell wall, but that's really spurious. But it gets rid of the odor, so I'm not saying don't use it. I call it the salad sauce. So those patients all smell like they're a Caesar salad. So, and then we get into the appropriate dressings, and they're all over the map. I mean, a dressing is a cover, it's a scab. That's what it is. It's there to cover the wound and perhaps do something. I can tell you this, in most of our stage 3 pressure injury now, we use negative pressure wound therapy, and by the way, we don't use the mechanical one. We use the electricity and suction, and the way God was supposed to make suction. We don't use those mechanical devices. They're expensive. They kind of work. Sometimes they don't. And if we think the wound needs to be addressed, especially in the outpatient setting, I won't say stage 2s, but almost all our stage 3 pressure ulcers, if possible, and payer will pay, we'll use NPWT because there's no data that supports that it increases the trajectory to healing much more quickly. And that gets to the last point, not every pressure injury is going to be healed with therapy. There are a bunch that require surgical intervention and correction. And again, it depends upon the situation, the patient, what the trajectory of their post-hospitalization is going to be, what is their caregiver system. I mean, there's lots of things that go into it, but if we see a stage 3 or 4 initially, certainly a stage 4, but a stage 3 even, depending upon volume and size, we may tell the patient, look, our job is to get this wound cleaned up, granulated, and then plastic surgery is going to do a flap. Because otherwise, we're going to be treating you for 18 months. And I'm pretty sure, we haven't done the math, but I'm pretty sure if we sat down and did the math, treating it for 18 months to 2 years is way more expensive than doing a flap. It's not necessarily more risky to the patient either, because the longer they have the wound, the greater the risk of comorbidities that occur because the wound is there, not the cause of it. Evidence-based practice, there are some therapies that we know has pretty good B-level evidence. Low and high frequency ultrasound might be beneficial. There's mostly C-level evidence there. But what this basically is ultrasonic mist irrigator, and it does help get rid of the biofilm. So, but for the most part, that's inpatient and it's in the OR. It's logistically problematic. Subatmospheric negative pressure wound therapy. I just mentioned that. And for stage 3 and 4, I won't say it's the gold standard, but it's getting close. Most of the static dressings, like using alginates and foams and things, remember now, once that fills up with the fluid, that it's not doing any good. It's there. So now you just got a goopy mess. Whereas at least with the negative pressure wound therapy, the bioburden is being sucked out and being transmitted back into the tubing. Obviously expensive, but again, I think somewhere along the line, I'd like to have a resident or a student do a paper and figure it out financially, because observationally, it appears that NPWT is probably a little cheaper. But the static dressings are a problem. Doesn't mean we don't use them. We do. Typically, alginates, most of the time with silver, because silver doesn't inhibit bacteria translocation and bacteria multiplication. It's not antibacterial in the sense that it kills them. It just slows down their ability to multiply. So we for the most part, use the silver alginates. In order to try to stimulate granulation tissue, remember those things like alginates and absorptives don't stimulate granulation. So if you really want to begin to stimulate granulation, debridement does, because debridement re-injures the skin and liberates growth factors. But we also then use some collagen products that help stimulate it. But there has to be an endpoint or an expected endpoint when you realize they're not working. That's part of the key. Is there's lots of things you can use, but you also have to understand they're not working and move on, or figure out why they're not working, and that's another whole talk. Some people often, especially proprietary centers, will say, well, HBO. Nope. There's absolutely no data that hyperbaric oxygen will improve the status of a pressure injury, except for a couple of places. One, it's because of radiation along with pressure. Yeah, probably there's some data that it'll help. By the way, it'll get paid for. It does help in times of an ischemic flap. It does help to support a graft, but it's 30 dives, which is really expensive. And not everybody has a chamber, although there's a couple of companies out there would like everybody to have a chamber. Anybody here from Boone? No. Boone has 2. I still haven't figured out why Boone Iowa's got 2.
We have 3.
You have 3?
We have 3.
Yeah.
How many do you have?
Because that sold the bill, but
We have 2.
The city has 2.
Yeah. We have way more than we need, and the University of Iowa has an 18 place.
Wow. What's that?
They have 18 chambers?
They have an 18 place chamber. It's as big as this room. Nurses walk around with a mask. They're a research center. They can do that. It's not a multi, it's a room.
Yeah.
And they're, it's kind of like being on an aircraft carrier, because they have those too, because those guys get the bends, which is really what that's for. Or carbon monoxide poisoning. HBO and wound healing has very little help. We've had it for years, and most of the time we don't have an indication. And we see 10,000 patient visits a year. So anyway. It is not established in pressure injury treatment in general, with the exception of where it has other indications, and osteoarterial necrosis, if that's there as part of the pressure injury. Yes, it has efficacy. It's not going to cure it, but it has efficacy. Then there's some other weird stuff out there like topical oxygen, which is nonsense. And then there are bioengineered skin substitutes. Well, it's nonsense. It's crazy. Red blood cells need oxygen, and they get them through the lungs. They don't get them because the air has oxygen in it. That's crazy talk. Anyway, they only, years ago, used to see these people at the wound meeting. They're not there any longer. Craziness. Total craziness. Bioengineered skin substitutes, on face, on a physiological basis, it doesn't make sense to use them, but we don't have enough discussion and research as to whether they would help. In order for those things to help generate keratinocytes or generate fibroblastic reproliferation, they have to be put on a very healthy granular bed. But if you have a very healthy granular bed, you're really sort of over the hump in care of a pressure injury. You just have to kind of protect it. Hopefully, if the patient is otherwise healthy, they're going to epithelialize, so you don't have to go to using them. So in pressure injury, the skin substitutes really, there's not a lot of data there. And logic says you probably don't have to use them. Evidence-based practice says, number one, in terms of documentation, you need to validate that it's pressure-induced. Use the PI classification system correctly, and it's really important to document the level of loss. We talked about that a little bit. Obviously support the host with regard to everything else that's going on, because none of these patients have only pressure injuries. Pressure is the result of something else, usually multiple something else's. Obviously these are common things: reduce shear and friction, manage incontinence, get rid of the sliding board, et cetera, especially in the outpatient world. Nutrition deficiencies. Pain management obviously is a huge issue. The good news is most pressure injury patients, that's not an issue, because that's why they got the pressure injury in the first place, but it can be an issue, so obviously it needs to be managed. And the bigger thing is, and I'm going to put, when I redo these slides, over here is going to be a /provider, patients, caregivers, and providers. most providers know nothing about this world. I mentioned this morning. Nutrition interventions are important. There's no question about it. Adequate nutrition is appropriate. It needs to be done. The stress that the wound creates its own nutrition deficiency, so you have to fix that. But we don't have a lot of outcome data there, and the outcome data that we do have is spurious as far as nutrition intervention and how it affects pressure injury. It's more logical process rather than, well, you know, if you starve people, they don't get well, so you better feed them kind of stuff. And that kind of logic, it makes sense. Give them a chicken, or whatever, pork, Iowa, give them a pork chop. Unless they're Jewish like I am, in which case give them a chicken. It's supportive, not curative, but extremely important. Evidence-based healing outcomes are problematic without question. We don't have a lot of evidence that we can rely on which is absolute. And that's part of the problem, because most of it is C level, some of it's even D, some of it doesn't exist. Logic, you can't just, I mean, it'd be nice to say, as I just said, you know, if you don't eat, you're going to get sick. I mean, that's a logic thing, but I can't cite an article that says that, you know, stuff like that. So, but we need to do a much better job going forward in the beginning of the, now getting into the third decade of the 21st century, with making sure we use evidence for our practice and stop using some folklore and snake oil and do things that are appropriate and work. First thing is to diagnose, and again, that's not for you. I'm a provider. She's a provider. That's for us. Make sure we know what that means. We have to diagnose and correct the cause of the issue and make the diagnosis appropriately in the first place, in which case that helps us create a pathway to success. Provider-based decision-making needs to be collaborative. I can tell you at Unity Point in our 5 hospitals, that's where we are, and we're moving forward on that. It's interesting because B and I know each other from the nutrition world, and when the nutrition world opened up, it actually was very much like the care world is, or we're a little bit further along, where it's a collaborative environment. It's not isolated, and it requires a whole bunch of people. Most of you are in the room. You need to understand the wound environment, and what is usually not known or not addressed is the systemic one and its relationship to the creation of the pressure injury, and that all has to be addressed. We didn't talk about blood sugar management, blood pressure management, all of those things. That has to be addressed, and ways around all those things, because the patient's physiologic environment needs to be as normal as it can be, because the reason the wound's there is because it wasn't. If it was, they wouldn't get the wound. It's not just no pressure. That's part of it. Typical and traditional therapies are always standard. No pressure, quote, no ulcer, end of quote, with caveats. And let the evidence guide us. The cheapest wound's not a wound, and the next cheapest wound is a healed wound. Questions? Come on. Yes?
When you talk about the unavoidable pressure injuries, that's the majority of the ones we see. Our patients they're on balloon pumps, impellas, they're on multiple pressors, so we can't really feed them because their gut's not absorbing it. And
Well, you can feed it, you're just not feeding it by mouth. Don't ever say you can't feed them. The dietitian over there, you're really mad.
yeah, or
You can always feed them.
we
It's
try
expensive.
we try to do trickle feeds on them, to keep their gut moving. But if they're on multiple pressors, optimize that.
It's just us in the room, you're right. There are some people you can't feed, I get it.
So when they're too sick to turn, they're prone, things like that, we document that. But when it goes like it's into a legal situation or whatever, is nursing documentation sufficient, or does there need to be provider documentation? Because I don't know that there's always provider documentation.
I'm not a lawyer, but I have enough knowledge to be dangerous. There's never enough documentation.
Because I don't feel
And again, I do a fair amount of advising, and I don't typically like to go to courtrooms My best friend is a Supreme Court justice in Iowa, and I know he was a tort lawyer first. He's a guy who played golf with 7 physicians, and he was a tort lawyer. We always treated him very nicely. He never paid for a drink, period. If there is a plaintiff, usually the reason for the complaint has nothing to do with the pressure injury. As we all know, something else created the patient's family or the patient to get ticked off. Most of the time the bill or somebody didn't treat him nice, but this is something that shouldn't have happened, quote unquote. And then the tort lawyer, the only way they get paid is if they win the case. And they're putting out a lot of money because they have to put it out up front because they don't ask the family to pay. So they're spending on the typical tort case is $100,000 up front on the part of the plaintiff's attorney. They're paying that out of their pocket. They may never recover. That's the fact. More often than not now, even in Iowa, the tort guys, unless it looks like $1 million case, they don't want to do it because they're not going to recover. Now, that being said, because I know more, I have more information to be dangerous. Documentation, and you don't document because you're concerned you're going to get sued. You do the right thing. This is what I saw. This is what it looks like. This is my Braden scale. Here it's done, and you do it when it's supposed to be done. I can tell you this one case in Chicago. This is a huge healthcare system in Chicago. It's the biggest one there, and they have a little problem because there are a couple of shifts there where the wound which occurred as a pressure stage 1 wasn't documented, and then 3 days later it's a stage 2, and there's a gap. There's a gap in the medical record, and I told them, I said, you know what, it's unavoidable, but they're going to focus on that means nobody was looking. That doesn't mean nobody was looking. We all know that. Somebody was busy, the pizza came, whatever happened, and they didn't document. It's the tort people will tell you, if it's not in the record, it didn't happen. I don't care what you said. If you went to confession and told your priest, it doesn't matter. It's got to be in the record. And the documentation needs to be appropriate. It shouldn't be overly documented because it's unnecessary. And that's the only, theoretically to protect yourself. The idea of practicing protective medicine, no, just do your job, including the provider. And I get that, and I wish I had an answer to that, because these things, again, you can put it in the nursing notes, you can put the Braden scale there, but if the provider doesn't say that's a pressure injury, and it doesn't go in then it isn't diagnosed in the chart. And that's probably what happened.
Is documentation by the people at this table sufficient in that
It protects your butt.
Okay.
It doesn't protect the providers. And when I give talks to provider groups, I tell you, the nurses are protecting themselves, and they should, and they're protecting the institution. But you need to protect yourself because they can't diagnose it. You can't. And if it's in their note, you're done, and you didn't say anything, then you're on the hook, and the hospital's on the hook. But the nurses protect. Should be.
So I can tell you one thing we've done at our facility is we see the pressure ulcers. Our notes get forwarded to our providers, thus it gets coded under the provider's name.
Okay, that's
The wound
nurses. We do the same thing, but it doesn't necessarily. The provider has to say that it's there.
Right.
Yeah.
But
That's,
the provider signs your notes,
If
right?
they sign you up, right, yeah,
so
they sign your
our
notes, right.
so it,
And what we'll do, when we have the wound service, I'm gonna be signing all the WOCN.
right.
Yeah, you just said that.
So yeah, that's a way to do it, at least from a tort protection staff. It's the
Right.
Tort Protection Service, TPS, you get a little tort protection service.
What do you include the family? What are you all saying with the family for, letting them know that they have a pressure ulcer?
Oh, yeah, well, again, in the outpatient world, we always have an advocate in the room if we can. But in the inpatient world, we have care conferences, especially the critically ill patients, and the family is supposed to. In fact, my wife is actually, as we speak, on a phone call with a care conference for her aunt, who's in a facility in
That's right, we do
Pennsylvania.
that.
But again, you need to document the care conference and who was there, and you reach out, but not everybody has an advocate.
Right.
And that's, you just have, again, document, don't over document, do your job. Document what you see, make sure you do what you're supposed to. Again, back to sort of, some of this is kind of logical.
Right.